I will be actually speaking about 3 different topics, or introduce 3 different topics. Most of it is focused on grade, and therefore I need to propose or show you my disclosures, which really have to do with co-chairing the grade working group and developing guidelines with various organizations, primarily the World Health Organization. There is no direct or personal for-profit payments. We've heard a lot about conflicts of interest. I will not talk about conflicts of interest or access to data in this presentation, because there are people in the room who are much more qualified to do that. But obviously much of that is at the heart of doing good systematic reviews and developing good guidelines. So in terms of guidelines and transparency of guidelines, there are 3 issues that I will touch on. First of all, why there is a problem. Then I will speak about transparency during guideline development and transparency in guideline or recommendation presentation. About 20 years ago, the person who led this field for quite a while, Dr. Eddy, said the following: it is simply unrealistic to think that individuals can synthesize in their heads some scores of pieces of evidence, accurately estimate the outcomes of different options, and accurately judge the desirability of those outcomes to patients. And obviously this is a statement in favor of doing systematic reviews, but what is hidden in here is that it goes beyond systematic reviews and making decisions on the basis of systematic reviews. What we commonly call clinical guidelines or clinical practice guidelines or healthcare guidelines in this article and in much of the writing of Dave Eddy was called practice policies. And from that, and through a number of definitions, the following definition developed at WHO, at the World Health Organization: guidelines are recommendations intended to assist providers and recipients of healthcare and other stakeholders to make informed decisions. So the emphasis here is on assisting healthcare providers in making healthcare decisions, not prescribing them or prescribing action. And recommendations may relate to clinical interventions, public health activities, or government policies. And also that is a pretty important piece of this definition that I think is still the most elegant definition of clinical practice guidelines, probably a bit better than that proposed by the Institute of Medicine in the recent writings. I will speak about clinical guidelines, which really are, as per Scott Weingarten, the desire of healthcare workers to offer and of patients to receive the best possible care. We want to make care more efficient and close the gap between what clinicians actually do and what the evidence shows. Now, if we take a look, these are my favorite examples. If we take a look at a couple of guidelines that are out there and deal with common conditions, for instance, chronic obstructive pulmonary disease, we quickly realize that guidelines haven't really done the trick. So if we just take this section from a COPD guideline on antioxidants, then we would find something that does make us happy. One, it is that a Cochrane review is actually mentioned in this particular guideline, and it says data from a Cochrane review of the study support a role for these drugs, which are mucolytic and antioxidant agents, in reducing the number of exacerbations of chronic bronchitis. And then it goes on to say that there is an ongoing large study. What most of you will realize is that it tells us about exacerbations of chronic bronchitis. It doesn't tell us anything about any other outcomes. Another guideline, published around the same time on the same topic, would have told you the following: antioxidants, in particular N-acetylcysteine, have been reported in small studies to reduce the frequency of exacerbations. And now it comes, leading to speculations that these medications could have a role in the treatment of patients with recurrent exacerbations, evidence B. And what you will see there is, or what you have realized is, that this really doesn't tell you much in terms of what you might want to do. It has about as many wiggle or weasel words in there as you could possibly put in a recommendation. And then finally, we use this example frequently to make the point for why there is more transparency in terms of evidence assessment in clinical practice guidelines required. We consider you're a practitioner, of a cardiologist perhaps, or a general practitioner who needs to make a decision with their patients about whether or not to use oral anticoagulants to prevent stroke and other outcomes in patients with atrial fibrillation. And let's just consider that we are dealing with patients who also have another medical problem, which is rheumatic mitral valve disease. If you were truly a clinician in Europe, you might look, despite the fact that it's an American healthcare guideline, you might look at the American Heart Association and find that they rated this the evidence underlying a recommendation for that, that is the use of oral anticoagulation, as evidence B with a class Roman I recommendation. The American College of Chest Physicians, a very prominent guideline developer in this field, would have said this is evidence A and an Arabic 1 recommendation. And then finally, the Scottish Intercollegiate Guideline Network would have told you that this is a Roman 4 evidence leading to a C recommendation. Now, most of you would have said as a clinician, this is pretty confusing, and it is similar to standing in front of a traffic light that gives you all sorts of messages rather than what a clinical practice guideline really should do and the recommendation really should do, and that is tell you clearly what the options are and what you might want to do together with your patient. Now, all of that is only moderately concerning. What is more concerning is when I tell you that these 3 clinical practice guideline developers looked at exactly the 5 same randomized controlled trials. There were 5 randomized trials, and they came to these different judgments about the evidence and the recommendations. It is not necessarily a problem that they came to different judgments. What is the bigger problem is that it was impossible to find out why they came to these different judgments, why there were different evidence assessments, and why there were different recommendations. Much of that has to do with evidence hierarchies in evidence-based medicine and practice guideline development. And it has to do with the fact that we typically use these hierarchies that were developed in the mid-70s, by the Canadian Task Force, where we simply look at randomized controlled trials as being the least biased types of studies. Cohort studies and case control studies would come below, with expert opinion at the bottom. So that those who develop clinical practice guidelines use these relatively simple evidence hierarchies in order to then assign a category of evidence that then inevitably leads to a certain type of recommendation. The reason for why this is a problem will be exemplified or will be shown over the next 5 minutes possibly. And that is, one reason certainly is that these evidence hierarchies are way too simplistic. But they are simplistic because, at least in our view, frequently those who develop clinical practice guidelines are not necessarily educated to assess the evidence in a way that would be more sophisticated. This is a pretty strong statement, but I can tell you that the poor evidence that I have is that if I ask clinical practice guideline developers when I give these presentations whether they can explain these 5 methodological concepts, and I ask this in rooms like this, I can tell you that very few hands typically go up. And that even works when we do the counter check, and that is who can not explain it. So the point is that clinical practice guideline development and the assessment of the evidence that is underlying recommendations is a complicated business, and to a large degree, the lack of transparency is due to the fact that those who develop them are not necessarily equipped to assess the evidence. The other reason is one that many of you, I realized that recently in France, are aware of, and that is that there is a lot of good evidence out there that doesn't necessarily need to be randomized controlled trial evidence that makes us confident in interventions. This is the example of randomized trials to prevent death from gravitational challenge, in other words, when you jump from an airplane through the use of parachutes. But what we always say is it's not a result of logical considerations or laws of physics, but it's really a result of observations and the large effects that are related to the use of parachutes. Having said this, there are a couple of factors that I mentioned on the slide before the parachute slide, and that is that there are methodological challenges that need to be assessed when we look at evidence hierarchies and when we look at bias in research. And there is a type of evidence that makes us more convinced or makes us equally convinced than a randomized controlled trial, and that we need expertise in order to assess this evidence. Having spent time on that, I will show you another example that is related to this. So this is a, I'm proud to say, close to summary of findings table, the first summary of findings table in the New England Journal, from an editorial that we recently published, where we updated the results or the and a systematic review that we had done for the Cochrane collaboration, and presented a summary of findings table in order to put a clinical trial in context. So in this particular editorial, based on a systematic review, we presented data for the use of heparin in patients with cancer to prevent various outcomes. Outcomes include death, symptomatic venous thromboembolism, what happens in terms of bleeding, both major bleeding and minor bleeding. And this is once again to show you both the format of a summary of findings table, where we assess for a clinical question both benefits and harms, that is the prevention of death, the prevention of symptomatic venous thromboembolism, and what happens in terms of harm. We present the number of people enrolled in the various studies for each of these outcomes. We present the relative estimates of effect and the absolute estimates of effect, both for the control group, in this case 500 deaths in patients who do not receive heparin, and what happens in the intervention group. Now, I will focus on this particular outcome, that is symptomatic venous thromboembolism, the prevention of symptomatic venous thromboembolism. And if I were to tell you that there were 9 randomized controlled trials that we found that enrolled almost 6,000 patients that were on average at low risk of bias, they were pretty consistent in their findings, and it was unlikely that there was complication bias, although we cannot exclude it. If I were to tell you this, and then if I were to ask you if you have confidence in these results, for this particular outcome, that is the symptomatic venous thromboembolism that I believe you can see, most of you would probably say, if I were to ask you how confident you are, we are probably pretty confident, somewhere up here. We are never 100% confident, but we are somewhat confident. That's at least what many other people would say. And in fact, when we actually went out and did a proper evaluation of the evidence based on the approach that I will introduce to you, we judged this as high-quality evidence. In other words, having high confidence in the estimates of effect, for that the data combined here are pretty convincing that there's a reduction in pulmonary pulmonary embolism and deep venous thrombosis. And this was based on a systematic review. I'll show you a different systematic review now. It's also a systematic review for a condition that I can hardly pronounce. It's a skin disease. And these authors did what I consider high-quality systematic, highly credible systematic review. They found a total of 15 evaluable cases of this skin condition, pityriasis, ruba, pilaris. They found 15 cases that have been treated with TNF antagonists. They said that in the literature, after doing, as I said, a complete review, 12 cases showed a complete response, an 80% response rate to TNF antagonists, the treatment that they were interested here. They said at the same time that there was selective reporting bias together with a lack of standard diagnostic criteria and established spontaneous resolution in pityriasis rubra pilaris. If I were to ask you now how confident you would be in this estimate of effect that is an 80% complete response, most of you would probably say, we are not very confident. And I would ask you, why are you not confident? This is a systematic review. Well, the issue is probably that there are significant concerns about, for instance, selective reporting bias and so on. The point here is that systematic reviews in itself obviously don't provide you with the confidence that you need in estimates of effect. It's the data that is included there. And what we have done with the great working group that Teddy briefly mentioned is we have thought about how we can define this confidence in estimates of effect. First of all, we thought we should be defining what we mean by quality of evidence, and it is in the words that I just said. The quality of evidence reflects the extent of our confidence that the estimates of an effect are adequate to support a particular decision or recommendation. And what it reflects is what is shown on this particular slide here. Two meteorologists, one saying to another, I figure there's a 40% chance of showers and a 10% chance we know what we are talking about. So it expresses the likelihood of an outcome, the 40% chance of showers that may be accompanied by a very tight confidence intervals, and the confidence that we know what we are talking about, or the confidence in an outcome, in an estimate of effect. We started this work about 12 years ago with the aim to develop, use and test then a common, transparent, and sensible system for assessing the confidence in estimates of effect and the strength of recommendations. There are over 100 systems out there, and we did this through an international collaboration, as I said, over the past 12 years with over 300 contributors, really from all sorts of fields of health research methodology, as well as clinical, from the clinical arena. The system, in the meantime, is used by many, many organizations, including the World Health Organization and the Cochrane collaboration. One of the big issues that we are facing right now with this, and I will ask you for your opinion, and what I call the elephant in the room is whether the confidence in these estimates of effect should be determined by the available or obtainable evidence, or whether the evidence about epidemiologic or research methods should determine our confidence. That's very important because the underlying issue here is that one of the frequent criticisms of using one assessment tool or one approach to assessing the confidence in the estimates is that it depends on the type of evidence that is available and that we can obtain. In GRADE, we've taken a slightly different approach. We have not said that it depends on the evidence that we can obtain, but we have said that we need an independent assessment system, whether or not we are dealing with public health interventions or clinical interventions. And in GRADE, the way that you could conceptualize it is that we start somewhere in the middle when we talk about confidence in estimates of effect. Because there is research evidence, and the reason why the research evidence exists is probably because there is some indication that there might be an effect. However, there are four, and we categorize it into four categories, high, moderate, low, and very low. However, there are factors that alter our confidence in the estimates of effect. And one way to conceptualize it is that if you randomize and if you do well, if you do randomized controlled trials well, your confidence increases and you end up towards the higher end of the scale. If you do observational studies, you stay somewhere in the middle. There are 5 factors that can lower our confidence in the estimates of effect that are very much based on what is available in the literature in terms of health research methodology. One is limitations in the detailed study design and execution, inconsistency in the findings between studies or heterogeneity, indirectness, that has to do with how well the evidence that you obtain really answers the questions that you have, imprecision, which has to do with how many events and people were enrolled in the studies, publication bias that we've heard a bit about or will hear a bit about, as well as reporting bias, which falls in factor number 1. But differently from most other systems, we've given explicit consideration to what really increases our confidence in estimates of effect beyond randomization. There are 3 factors. One is a large magnitude of an effect, such as in the parachute example. A second is a more complicated one applying to observational studies. That is, if opposing plausible residual bias or confounding would have reduced an observed effect or increased an effect if no effect was observed. And the third is dose-response gradient. So when we apply these factors, we do this for a body of evidence. Our initial starting point is that randomized controlled trials start as high quality, observational studies as low quality. 5 factors can lower it, 3 can increase it, and we end up in 4 categories after this assessment. Now, the quality of evidence assessment is only one piece. And as I said, we do this in 4 categories. Basically, a result of an assessment of the methodological quality and the likelihood of bias from applying the evidence to our healthcare question. And we do this by outcomes and across outcomes, as you've seen in this heparin and cancer example, where we looked at DVT, PE, and death separately. And but we separate this from developing recommendations, differently from many other systems that had been out there where there was a direct link between evidence and the strength of recommendation. We say that recommendations are somewhat independent. We develop recommendations based on and categorize them into 2 grades, either weak, also known as conditional, or strong, and we make recommendations for or against an action based on the balance of benefits and downsides, values and preferences, resource use, and quality, and the confidence in the estimates of effect that I already talked about. Those of you who are more interested in this topic, there's a series of papers appearing in the Journal of Clinical Epidemiology, in fact 20 papers that are coming out. When we make recommendations, we've taken very much to heart the evidence-based healthcare decision model by Brian Haynes and colleagues, or that was first put forward by Brian Haynes and colleagues, that suggests that decisions should be made on the basis of 4 factors. One is the clinical state and circumstances. Where are we seeing our patients? What type of patients are those? For instance, are we in a primary care setting? Are we in a tertiary care setting? What are the modifying or contextual factors, prognostic factors in a patient? We combine that with population and societal values and preferences, and then look for the research evidence and integrate that with our expertise. Now, this is a pretty good model, as you can see, but it's 10 years old. And I think it doesn't necessarily reflect what we're doing in grade. What we probably are doing in general in clinical practice guideline development is we look for evidence of these clinical states and circumstances. That is, we look for evidence of baseline risks and context for a given population. We also should be, and we are not necessarily doing the greatest job, look for evidence of population and societal values and preferences rather than just assuming them. And finally, when we say research evidence, both of these factors are supported frequently by research evidence. What we are really looking for is evidence of effects. Those may be effects for therapeutic interventions or for diagnostic tests and strategies. So what we need to do is integrate these various pieces of evidence, sometimes good pieces of evidence, sometimes not so good pieces of evidence, in order to formulate recommendations. And that is one of the underlying principles in grade. We have tried to make these judgments explicit, regardless of whether the evidence is of high quality in these, for these various factors or of lower quality. We use our expertise to then formulate recommendations. So let me talk quickly about recommendations. The strength of a recommendation reflects the extent to which we can, across the range of patients for whom the recommendations are intended, be confident that desirable effects of a management strategy outweigh the undesirable effects. And I said that we make strong or weak, also called conditional recommendations. These 4 factors that you've seen in the healthcare decision model by Haynes and colleagues are really reflected in our decision determinants or recommendation determinants. That is, if we have a high confidence in the estimates of effect, in other words, if we have good quality of evidence, we are more likely to make a strong recommendation. If the balance between the desirable and the undesirable effects is clear, we are more likely to make a stronger recommendation if there is greater net benefit or great net harm. If we know about the values and preferences that underlie a recommendation, and in particular if there is low variability, we make strong recommendation. And then if an intervention is very costly or resource consuming, the less likely is a strong recommendation. So that in other words, what we are doing is similar to what we do in healthcare decision modeling. We are looking at the effects of an intervention and how important the outcomes related to this intervention are. And we do this both for health outcomes as well as resource utilization data. And then we weigh the balance of the benefits and the desirable and the undesirable consequences in a way that when we are when the balance tips slightly in favor of an intervention, we make a conditional or weak recommendation for an intervention. If it tips slightly to the other side, we make a weak or conditional recommendation against an intervention. And when the balance is clear, which can be based by, both on complex decision modeling as well as the back of the envelope decision modeling, when the balance is clear, we make strong recommendation either in favor or against an intervention, depending on whether the benefits outweigh the harms or vice versa. So, coming back to the type of recommendation that would result from the systematic review that I presented to you, the summary of findings table that I showed to you in the very beginning. This systematic review was actually done to produce clinical practice guidelines, and as you can see, there was a possible reduction in death that was borderline statistically significant, although the hazard ratio, possibly a better way of expressing survival here, was statistically significant. There was a reduction in symptomatic VTE. There was a equivocal result for major bleeding as well as for minor bleeding, both not statistically significant, indicating, if at all, only a very small increase in the side effects. So in other words, if we look at the quality of evidence and these results, we had at least, as per grade, we had at least moderate quality evidence that there might be either more benefits than harms. What did the guideline panel do with only part of this information? Because I must confess that they did not have this last trial. The guideline panel that actually worked with this data, the American College of Chest Physicians, they made the following recommendation. In outpatients with cancer who have no additional risk factors for VTE, we suggest against routine prophylaxis with low molecular weight heparin or low-dose unfractionated heparin, and they made this a conditional or weak recommendation against this intervention. As opposed to most other systems, to come to closure, as opposed to most other systems where the moderate or high quality evidence would have led very likely to a strong recommendation in favor of using this intervention, this group made a suggestion or a weak recommendation against its use. And that had to do with a number of factors, including that there were issues obviously around subgroups, about prognostic factors, but most importantly, that the group valued the still existing risk of bleeding very highly and was very concerned about resource utilization. In other words, every patient having to take heparin. So that the transparency there really comes from describing very clearly, according to these 4 factors that I introduced to you, the confidence in the estimates of effect, the balance of benefits and downsides, the values and preferences and resource utilization, that considering these four factors was done explicitly and transparently and led to a recommendation against this intervention that many would have just suggested. We've provided then what the implications of such conditional or weak recommendations are, and in this particular case, for patients it would mean that the majority of people in the situation would want the recommended course of action, but many would not. In other words, the conditional recommendation that I just described to you would lend itself to the use of decision aids and to an informed decision by patients where a not small minority of patients may say, we should probably still use heparin, or we would want heparin to reduce venous thromboembolism and reduce our chance of death. We have implications for strong recommendations, which would have been a result of many previous guideline development systems or grading systems for this particular type of recommendation, where most people in this situation would have wanted the recommended course of action, and only a small proportion would not. And you can tell that that would have been not very applicable to the recommendation that I described there. So to summarize, what we do in GRADE in order to enhance transparency in guideline development is we emphasize the relation between systematic reviews and guideline development, and we emphasize that a systematic review should be informed by questions that likely involve those who use the evidence in order to develop healthcare recommendations, by specifying clearly what the underlying question is in the PICO framework, by identifying all outcomes that are critical or important or not important for decision making, such as in the example here where I presented 4 outcomes to you. And the panel makes judgments about which are more important, such as major bleeding, venous thromboembolism, and death, and those that are not or less important, such as minor bleeding, makes decisions around these outcomes that should be presented. We assess the quality of the evidence across these outcomes according to these 8 or 9 factors that I described to you, presented transparently in summary of findings tables or evidence profiles. And as I said, we rate the individual outcomes according to grade in these 4 categories and the 9 or 8 factors where randomization initially increases the confidence in the estimates of evidence of effect for a body of evidence. We provide an overall grade that is depending on the input from panel, in particular as it comes to applicability and generalizability. And this overall grade, together with the evidence profile, is fed back to the guideline panel that then develops a recommendation either in favor or against an intervention, either strong or weak, based on the 4 factors that I described to you. Writes this clearly in a guideline, formulating the recommendations clearly with a clear description of what the underlying values and preferences, the underlying research data, and the possible benefit, balance of benefits and harms is. Thank you.